So, good evening, everybody. My friends, my colleagues, and if there are any teachers also. Today, we are going to start this new updated pediatric tuberculosis guideline. Initially, when we did this guideline, it was under the benchmark of uh, RNTCP, Revised National Tuberculosis Control Program. But now we have went a step ahead. Now it has become National Tuberculosis Elimination Program, from control to elimination. By elimination, we are trying to achieve this goal by the year 2025. There should be less than one case per million population. That means less than one case per 10 lakhs population. So today I'll be giving you an introduction to this course guide and a brief initial basics of tuberculosis. So before coming to the, sorry, before coming to this, before giving the introduction, I'd like to tell you this course, we will do it in a series of lectures to be given by myself, Dr. Nupur Ghosh, Nupur Ganguly, Dr. Jaideep Chaudhary, and Dr. Khya Ghosh. So the 2 days has been earmarked. One is Tuesdays and Thursdays we'll be doing this. And we expect to cover the entire course within few weeks. So with this, I come to my childhood tuberculosis. In our younger days, the tuberculosis was diagnosed by conventional tools. Any child with chronic symptoms who would come, we would first do an X-ray chest and also a Mantoux test. Bacteriology in those days was usually not done because of two important reasons. Number one, child could not bring out sputum. They usually swallow the sputum, and even if you can able to catch hold of the sputum, it was possibly bacillary. Cultures we read in the textbook, Lowenstein Jensen median culture, which will take about 3 months for the report to come. In those days, we didn't hear of Bactet, and MGIT was something which was Latin to us. So most of the cases was diagnosed clinically, and more experienced doctor, he gave his diagnosis with uh, full throttle, and we followed those things. We never thought of doing a smear because it was very poor in sense, only 10% positivity, and culture was out of question. So more experienced the doctor, he had the right to start or stop TB, and entire treatment was only based on, to say it truly, was assumption because there was no science behind it. And even today, to some extent, diagnosis of tuberculosis is to some extent on assumption. And we assume even today that all initially diagnosed TB is usually drug sensitive TB. And we start treatment, and if they don't show appreciable result, then we think of drug resistant TB, or those children who comes from a very background of drug resistant TB, we think of those. But if we think all TBs to be drug sensitive, there are two very important problems. Number one, if you treat a drug sensitive, drug resistant TB as drug sensitive, you amplify the resistance. What do you mean by amplification of resistance? What you do, you kill the sensitive organism and allow the resistant organism to multiply. And this results in spread of drug resistant TB, which has increased to a very huge extent these days because of this. So now the paradigm has shifted. Now in all cases of tuberculosis diagnosis, we need to do an upfront drug sensitivity testing also to see whether it is rifampicin or INH resistant. So the diagnosis of TB in yesteryears was microbiological. We need to demonstrate the organism by smear. But now it has changed. We don't do microbiology, we rather do bacteriology. It is the rapid molecular tests has come. We have shifted from microbiology to bacteriology, and rapid molecular tests has given us very two important insights. Not only we can diagnose TB, but also we can very rapidly diagnose whether the tuberculosis you are seeing is rifampicin resistant or not. So the goalpost has moved. We want to do MTB detection along with the same time MTB and rifampicin resistant detection. So both should go hand in hand. Previously, our attempt was first to detect MTB, then resistance, but these two should go hand in hand these days. So this has been only made possible because of rapid molecular tests are available. And now it has been decided that all cases of TB, you need an upfront universal drug sensitivity testing. So that's the reason we should do in all cases of newly diagnosed TB. So these are the few important chapters in the module which we'd like to cover. And today I'll be covering the first two, what is new in the strategy, magnitude of the problem, and the natural history of the disease. Subsequently, next Thursday, Dr. Nupur Ganguly will be talking of pulmonary TB diagnosis, part 1. So coming to the magnitude of the problem, let's see where do we stand. It has been seen that the entire effort of the world is to reduce childhood mortality. And to reduce childhood mortality, the most important thing, you must reduce under 5 mortality. There are 5 pillars of under 5 mortality. First is prematurity, next is pneumonia, third is diarrhea, and fourth is intrapartum. That means the problems related to child delivery, mostly birth asphyxia. And there's a fifth pillar which is known as others, and the contribution of others to the childhood under 5 mortality is 10%. And tuberculosis has been placed somewhere in this others. It has been estimated in the year 2018 that there should be 2.2 lakhs of children in India is suffering from TB, which is nearly 1/4 of the total global TB burden. And most of the childhood TBs are pulmonary TB, though extrapulmonary TB is much commoner in children as compared to the adults, but pulmonary TB contributes to the major part. But of these 2.2 lakh estimated TB, we are able to diagnose very few. We are not able to diagnose this 2.2. So the tuberculosis has become a blind spot. How much tuberculosis contributes to others also is not known. And that might be one of the reasons why the health planners everywhere has not given that much importance to tuberculosis. So the under 5 total estimated TB burden is 2.2 lakhs, but actually we are diagnosing a very few of them. The red and the blue bars you are seeing in this white triangle is actual diagnosis, and the rest white, both on the left and the right side, is we are unable to diagnose this. So the most tragic part is that of all the childhood tuberculosis cases, we are able to diagnose only 31%. Rest 69% is undiagnosed. So more than twice the number remains undiagnosed. And here lies the problem of childhood tuberculosis. So here you see huge detection gap in under 5. So why? Why this detection gap? Diagnosis of TB in adults is very simple. All you have to do, you take a sputum smear and do a microscopy, and the results are available within few hours. And fortunately, this microscopy is now available in every corner of the country. And if the sputum is positive, then in case of adults, we do a radiology. So the algorithm in adults is from bacteriology to radiology. Bacteriology is radiology. But in children, bacteriology is not possible. Bacteriology is not possible because smear samples are not there. So what we do, usually we first do a radiology and then we try to do an bacteriology. So we try to retrofit childhood tuberculosis in the adult algorithm. This is just like putting a square peg in a round hole. So that's the reason we are not able to diagnose that much of TB cases. But now time has come, we should realize that the children are not mini adults. In no way we are trying to diagnose tuberculosis in children as an adult module. We are not going to fit a child in the adult algorithm. So we need a separate focal point and separate involvement of the pediatricians. And the pediatricians should be very much aware of what are the new diagnostic modalities and what are the new things which have come in tuberculosis. So underdiagnosis was a major problem. Child-specific diagnosis and management is needed these days. And the entire idea of this course to train the healthcare providers to the new standard guidelines, how to diagnose TB. So more we diagnose TB, more we understand about the problem and more we can reduce the mortality in case of children. So with this, I come to my subject proper, the natural history of childhood TB. Before starting this, I'd like to tell you a few important points. Tuberculosis is an airborne disease, and there are certain differences between child and adult tuberculosis. In adult tuberculosis, it is mainly the pulmonary tuberculosis or the pulmonary lung parenchyma is involved, but in childhood tuberculosis, it is the glands. The mediastinal and hilar glands are more involved than the pulmonary tissue. Adult tuberculosis is multibacillary, whereas childhood tuberculosis is paucibacillary because most of the bacilli are inside the glands. The chances of infecting others is much higher in adult tuberculosis, but it is less with childhood tuberculosis. But don't think that childhood tuberculosis does not infect others. It can also infect others unless and until it is an extra pulmonary TB. Childhood tuberculosis has a very high chance of dissemination here and there throughout the body, whereas adult tuberculosis usually restricts itself inside the lungs. And finally, adult tuberculosis heals by fibrosis, whereas childhood tuberculosis heals by calcification. And another important point you should remember, when any child or anybody is seeded with tubercle bacilli, first he develops an infection. This infection is not disease. If the infection multiplies or proliferates, then it will produce symptoms and give rise to disease. So you should remember the difference between infection and disease. Infection, we call it latent, whereas disease is manifested. So tuberculosis is a disease in continuum. When a susceptible child is exposed, he develops infection, and whether the infection is going to disease, each step has a measurable probability or predictable probability. It is the balance between the virulence of the organism and the immunity of the child which determines whether the child will progress in what direction. If the immunity of the child is less and virulence of the organism is more, the infection will land up in disease. And if still this continues, the disease will progress. But if it is the other way around, the virulence of the organism is less and virulence of the organism is less and the immunity in the child is high, then the infection will not manifest into disease, but it will remain latent. And later, if time comes when this balance is tilted, the infection might reactivate and give rise to reactivation disease. So usually a source case is usually an adult in case of children. But you should also remember the children can also infect others, but the chances are less. The source case is usually an adult, and it has been seen that if the adult is smear positive, then the chances of infection is much higher as compared to an adult who is smear negative. And there are, depending upon the type of contact, the chances of infection varies. There are three types of contact. One is household contact, the second is close contact, and the third is casual contact. Supposing you are traveling in a bus, the person who is sitting next to you for say minutes or hours is a casual contact. Here the chance of infection is much less. But a household contact, by household contact we mean when you share the same premises or the same roof for one or more night, it becomes a household contact. And who is a close contact? When you share the same premises or roof for a prolonged period of time. For example, the mother who is living behind the small kid in the daycare center at 9 o'clock in the morning, again to collect him at 6 in the evening, is a close contact of the person who is taking care of the child in the daycare center. So I think by this time you have understood the three types of contact. Casual contact, only for few minutes or hours. Household contact, sleeping under the same roof for one or more nights. And the close contact, sharing the same premises or under the same roof for a prolonged period of time. It is with the household contact and the close contact where the chance of infection is much higher as compared to casual contact. So let's see, when a source case is, when a contact is exposed to a source case, there are two possibilities. 70% chance that the contact won't develop any infection. And if the contact doesn't develop any infection, or in other words, the contact is not seeded by tubercle bacilli, there is no disease. But 30% will be infected. That means 30% of the person who is exposed, or children who is exposed to a source case, will be infected. That means he is seeded by tubercle bacilli. And let's see what happens further to this infection. Depending upon the, as I've told you, virulence of the mycobacteria and the immunity of the child, 90 to 95% the infection will be latent. That means the infection does not manifest any further because his immunity is so strong. So 90 to 95% of the infected is not going to develop disease, at least for the time being. The infection remains latent. And this 90 to 95% is usually seen in older children, adolescents, and adults. But 5 to 10%, the infection will progress into a primary disease. And as I've told you before, smear positive is highly infectious, smear negative is less infectious, and extrapulmonary TB is non-infectious. So in case of adults, adolescents, and older child, 90-95% will develop latent infection, whereas only 5 to 10% will develop primary disease. But if the infection occurs in infancy, that means in less than 1 year age, then the chances of developing primary disease is very high. It is more than 50%. That's the reason why you give prophylactic INH. But as the child grows older, the risk of developing primary disease comes down from 50% to 25% in between 1 to 5 years, and thereafter it further lowers down. So I think you understood this, how an infection is going to behave or develop. Younger the child, more chance the infection will land up in disease. Older the child, less chance the infection will remain latent. But in the subsequent years, if due to some reason the host immunity falls down, for example, say the child has an attack of HIV or the child has an attack of severe acute malnutrition, then this latent infection, they will reactivate, they will flare up, and they will give a late reactivation disease. So this far we have learned tuberculosis infection, primary disease, and late reactivation disease. So let's proceed further. So what are the risk factors for tuberculosis infection, and what are the risk factors that tuberculosis infection will develop into tuberculosis disease? So the risk factors of tuberculosis infection is in our country where the TB is highly endemic. If a children lives in a family who has HIV, if there is overcrowding, tobacco smoke is one of the principal damage causing to the ciliated epithelium of the respiratory tract. Biofuels are also causes similar things. So these are the factors in which the chances of infection will be higher. If the source case, I have already told you, it has a cavitary disease or smear positive. If the source case does not follow any cough hygiene, often we see people who spit indiscriminately, even in their room. So those are the cases where the chances of tuberculosis infection is much higher, as I've told you, more higher than 5 to 10%. And more closer the contact with the source case, more chances of infection. Which is the most closest contact? The most closest contact is mother and child. So if a mother has infection, there's very high probability the child will also have. So these are the risk factors for infection. Now let us see what are the risk factors for the TB disease. I told you before, younger the child, more chances the tuberculosis infection will go to tuberculosis disease. If the child has HIV, if the child has any infection or any abnormality which reduces the immunity of the child, for example, malnutrition post measles will also give rise to tuberculosis disease. And if the child is not BCG vaccinated, the risk of disseminated disease is further higher. So these are the two important risk factors. And if you don't give prophylaxis, in certain cases of tuberculosis infection, then you develop tuberculosis disease. So this is the tuberculosis incidence. By incidence, we mean the number of new cases in a given number of population, whereas by prevalence, we mean number of old and new cases. If you see, the incidence of tuberculosis is very high in the early years of life, less than 1 year. And not only the incidence of tuberculosis is very high, the incidence of disseminated tuberculosis is highest in this age group. Tuberculosis meningitis, miliary tuberculosis, like this. As the child grows older, the chances of tuberculosis infection going to tuberculosis disease starts falling. And the safe period is the school age, between 5 to 10 years. And after 10 years, during the adolescence, there is a slight increase. I don't know the exact reason why this is increased, but during the adolescent period, the type of tuberculosis also change. It is mainly what is seen is pleural effusion and cavitary type of tuberculosis involving the apical parts of the lungs. These are known as adult type of tuberculosis. Chances of high In the early years of life, the safe period is the school age, and thereafter there is slight increase. So now we have learned what is tuberculosis infection. Now the tuberculosis infection, if the virulence of the organism is high and the immunity of the host is less, will now develop into a primary complex, or it is known as Ghon's complex. The Ghon's complex has three parts. It has a lung parenchymal part, which is known as Ghon's focus, and it has a lymph node part, enlargement of the lymph nodes. And connecting these two is the lymphangitis. So the Ghon's complex consists of three parts: Ghon's focus or primary pulmonary complex, enlarged glands, and connecting these two by tuberculous lymphangitis. This primary complex, patient may have only non-specific mild symptoms and it might go totally unrecognized. Also, it might so happen that the lung parenchymal part is very small, you cannot detect it, whereas the hilar component is very larger. Or it might also happen the other way around, where the primary complex is very large, the lung parenchymal complex is very large, which will resemble as a pneumonia, and you cannot see any lymph nodes. And this primary lung complex are usually seen in those areas of the lungs which are mostly highly aerated in case of children. That is the anterior parts of the upper lobe, the middle lobe, and the superior parts of the lower lobe. The primary complex may appear, just I have told you, may appear just like a pneumonia. And these are the pneumonias which are non-resolving even after giving antibiotics. So one of the differential diagnoses of non-resolving pneumonias, that's the reason it is tuberculosis. So again, I repeat, the Ghon's complex consists of three parts: lung parenchymal part, enlarged node, and connecting lymphangitis. And many a times you cannot see these three parts together. It might present with only one. So let's see how the thing progresses. So the tuberculosis infection has now come to an tuberculosis disease, or the first step is primary complex, which is also known as Ghon's complex, and it consists of two important parts: lung parenchyma and lymph node. If the immunity of the child is good enough, the Ghon's complex might be contained. It does not expand any further. It undergoes natural healing. And fortunately, if you are able to pick up a primary Ghon's complex because of any reason, the child has come to you, if you treat this, then also you can contain the primary complex, but it is not possible to kill all tubercle bacilli, because dormant bacilli who are not multiplying, you cannot kill them. But in the later part of life, if due to some reason the immunity of the host decreases, then you can have a reactivation disease. So a primary Ghon's complex can undergo natural healing, or it can be treated and then healed. So this I was telling, the Ghon's complex consists of two parts. One is lung, another is lymph node. Now, a very important question: is the reactivation rate is different between naturally healed versus treated case? In whom the chances of reactivation is higher? Let's see the answer. The answer is risk is much higher with natural healing. That's the reason, though we know that the primary disease might heal by itself, you do not allow to naturally heal. You should always treat if you are able to diagnose, because the chances of reactivation in natural healing is much higher as compared to those who have been treated. So Coming to the two parts of the primary complex, one is Ghon's complex or the primary lung complex, another is the lymph node complex. Let's see what happens to the primary lungs complex. The complex consists of two important things. One is regional lymph nodes, another is parenchymal lung, which is also known as Ghon's focus. So the regional lymph nodes in the hilum and in the mediastinum, they might enlarge and they might cause important big airways that they are in the hilum and in the mediastinum. They might involve the airways. It might cause a complete obstruction of the airway or partial. If it causes complete obstruction, then you have collapse of the lung. And if it causes partial obstruction, then you have emphysema or air trapping. Also, it might so happen that the regional lymph node can break into the airway and they might spread through the airways or intrabronchial spread. Intrabronchial spread giving rise to bronchopneumonic consolidation. And if the child is able to cough out the collected material, then he can have a cavitation. And also what can happen to the lung parenchymal disease? The lung parenchymal disease might spread and also it can cause cavitation with intrabronchial spread, or the lung parenchymal disease might open into the adjoining structures or adjoining organs. It might open into the pleural space to cause pleural effusion. It might open into the pericardium. The heart is very near. Then it will give rise to pericardial effusion. Or the lung parenchymal disease might catch hold of an pulmonary vessel and then spread to give rise to miliary TB. So now this is known as progressive primary TB. So we had infection, primary disease, and progressive primary disease or progressive primary TB. These are the three parts. Now let us take a small exercise. What you are seeing in this X-ray, we can see a node here, we can see another node here. So these are right paratracheal lymph node and right hilar lymph node. But the lung parenchyma is relatively clear. So this is a primary TB with lymph node disease. Fortunately, till this time, there is no airway compression or there is no obstruction or collapse. So this is the primary TB. Let's see what you are seeing here. We are definitely seeing a lymph node here and a lung parenchymal component. And here we can see only lung parenchyma without any lymph nodes. So these are all primary complex. This is the full primary complex which has a pulmonary lymph node and this is only pulmonary. There's no visible lymph nodes. Here what we are seeing a thick walled cavity. There is no air fluid level. A thick walled cavity inside a consolidation. And here what is seeing a consolidation which is showing a breakdown or cavity. So this is a cavity within a consolidation. This is a cavity with consolidation. So what we see, this is a progressive primary disease. The disease has progressed. Parenchymal cavitation with consolidation. Here, what you see, look very carefully what you can see. What you can see, the lymph node has compressed the left main bronchus. There is airway compression and this airway compression has resulted in air trapping here. It is not fully compressed, it is partially compressed. And then bronchoscopy was done which definitely showed that the lymph nodes are impinging on the left main bronchus. So it is a lymph node disease with airway compression. There is a hyperinflation of the lower lobe and fortunately till now there is no collapse. So this is also a progressive primary disease. This is the miliary TB. What are the other diseases which can cause similar picture, you should always remember tropical pulmonary eosinophilia, very common in our country, pulmonary hemosiderosis, histiocytosis X, even metastasis in the lung. These are the few important causes of miliary-like shadows. Not all miliary shadows are tuberculosis. There are other, so you have to investigate properly. So coming back to the, we 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 have learned that tuberculosis infection might be contained naturally, or it might be contained if you get treatment, but you are not able to remove all the organisms. So if in the later part of the life, due to some reason, the immunity of the host reduces, then there might be reactivation of this infection. They will give rise to post-primary tuberculosis, and this post or reactivation tuberculosis is usually seen in adolescents and adults. 50 to 90% cases are from reactivation of a previously dormant primary infection. And unlike primary pulmonary infection, which you see in children, it is the apical lobes and the posterior segment of the upper lobes are mainly involved. And focal and patchy heterogeneous consolidation with cavitation, pleural effusion, these are more commonly seen in post-primary TB, and tuberculosis are also seen. So here are a few examples of post-primary. Here you see it is mainly fibrosis, and it is the apical portion of the lungs where cavitation usually occurs. So cavitary pneumonia in left upper lung, and this is also a fibrocavitary pneumonia you can see. These are all reactivation or post-primary tuberculosis. This is another interesting X-ray. If you see very carefully, you cannot make out the right border of the heart. So most likely it is a middle lobe consolidation. And one of the very important cause of middle lobe collapse and consolidation is tuberculosis lymph nodes. So lymph node disease with airway compression, lateral view shows the characteristic middle lobe compression. This is another where you can see aortopulmonary lymph node with consolidation. So coming to the summary of the whole case, what I've told you is this exercise of primary, post-primary and reactivation tuberculosis is useful. The answer is no, it is not useful. Where lies the problem? The problem is this has been done thinking that you would be seeded with tubercle bacilli at the beginning of your life. Thereafter, you develop post-primary TB or reactivation TB. But this does not hold true in TB endemic area because you are constantly exposed to tubercle bacilli. So what happens in TB endemic areas? There are repeated episodes of infection, and but in our exercise we presume that we are seeded with tubercle bacilli in the beginning of life, and that same bacilli progresses. But here, both reactivation and reinfection is going side by side because tuberculosis in our country is a high endemic. So reinfection is equal as reactivation here. And we cannot say whether if a adolescent comes with TB, whether it is reinfection or reactivation, the chances remains same in both. But why this has been done? The entire exercise was done to give you an idea how TB progresses. But it is very important to distinguish between cavitary and non-cavitary disease because in cavitary disease, the bacterial load is very high. He is a high chance of infecting others. More the bacteria, the chances of drug resistance is also high because more of drug resistant organisms will be harbored there. The outcome of cavitary disease is relatively poor as compared to others. And as I've told you before, the cavitary disease is highly infective. So with this, 45 minutes has gone, and We will come to the next session on Thursday where Dr. Nupur Ganguly will take. So with this, I complete my session. Shall I stop sharing?
Yeah, I think you can stop sharing. Yeah.
If you have any
They can
question,
put in the chat box. If there is any question, they can put in the chat box.
I don't think there's any question, or I can wait for a few minutes.
কারো কোনো কোশ্চেন নেই?
Question or key? The basics.
The question, yeah, questions will probably come in the subsequent lectures, and then there can be more interaction. So the next episode on Thursday.
Next episode on Thursday, Dr. Nupur Ganguly will be taking this.
Wait, there is one chat. Oh, Dr. Vasudev Patro.
What a revelation! Revelation! Oh, what a revelation! Thank Vasudev for your nice words for me. Thank you.
Okay, then we'll call
Okay.
it.
না আরেকটা এসছে নাকি masking in the corona masking in this corona epidemic incidents undiagnosed. Yes, masking, actually masking, not masking, now the entire effort of all our things is going to corona. So there might be some, but what I feel these days, we are seeing a huge increase in TB cases. I don't know, I think everybody will be agreeing with me. Only a few days back, we saw a child, and rather an infant, we hardly 1 year or 1 year, 2 months old. He has come with a TB spine. And the most common cases of TB spine is usually dorsal vertebra. He has come with the TB spine in the lumbar vertebra. So these unusual cases, unusually we are seeing. Diagnosis, management, complication, and subsequent, yes, subsequent station they will take.
How common is transmission of pulmonary TB from child to child?
There are two important things. Number one, in children, the tuberculosis is bacilli, so the chances is less. And number two, the child never brings out the sputum. In fact, he swallows it. The tubercle bacilli are seen in the pulmonary content, not in the saliva. So, in chances of child to child infection is very less as compared to adults.
There is one question. Previously healthy adolescent now has severe disease, TB, TB disease. I mean, should we investigate for primary immunodeficiency? Secondary
No.
ruled out.
Primary immunodeficiency, I told you before, in the chances of TB or the incidence of TB, there's slight increase during adolescence. So no wonder if you find there are some other evidences of immunodeficiency, supposing the child is failing to thrive, he is suffering from multiple unusual infections at unusual places. So those are the pointers. So then you have to think. Otherwise, in adolescence, there's a little surge of tuberculosis.
So
This is
the HIV is to be excluded in
yes,
adolescents, like
yes,
they have all these.
yes.
So if the adolescent is all right from the beginning, the chances of immunodeficiency will occur only in HIV and if there's any malignancy.
Now, actually, TB and HIV goes hand in hand. This is an epidemic which is going on, both TB. So, in all cases of TB, it is mandatory that you have to do an HIV testing. And if you have a faintest doubt that it must be a drug-resistant TB, then always you have to do an HIV. Bacteriological diagnosis in children will be dealt subsequently. And now an important thing has changed. Previously, it was a microbiological diagnosis. Now it has become a bacteriological diagnosis because we are depending more on molecular techniques rather than microscope. Should we investigate previous
More on molecular diagnosis rather than emphasis is
microscope?
more on molecular. Yeah.
Yes, molecular diagnosis. So these things will be dealt uh, tomorrow night, I think day after. So every Tuesday and Thursday we'll have. ठीक है. तो जय